Well, good afternoon, ladies and gentlemen, and welcome to our Alert Education Evening for Health Professionals. We're delighted that you're here to join us tonight. For those who don't know me, my name's Louise Kohlmeyer and I'm the Lymphedema Program Manager here at Alert Program. And for those of you who it may be your first time to attend one of these events, the Alert Program stands for the Australian Lymphedema Education, Research and Treatment Program. And we're really delighted that we have international visitors to come to our program to see what we're doing here, and we're really delighted that Professor Vaughan Keeley from the UK is going to be our main guest speaker tonight. So I'm sure everyone's come for that, to hear Vaughan and to hear the topic that you're going to be presenting. I'd also like to acknowledge and welcome our director, Professor John Boyages. Normally he is doing this MC role, but he's decided to create a bit of attention for himself. He is up in the front row, but he decided to try a bit of gardening at home last week or 2 weeks ago, which he doesn't normally do, and had a little fall in the backyard, I think. So I don't know if he wanted attention or he just didn't want to see us, but thank you, John. Just on a practical note, anyone needing bathrooms, if you just go out the main door, behind the lifts and to the left, there's male and female bathrooms. We are going to have our main guest speaker. Vaughan will speak to us initially. Then we will have time for questions and answers and discussion. And then we're going to welcome our second guest speaker, Dr. Helen Macquarie, to really give us an update on what's happening in lymphedema, which a lot is happening in this area at the moment, and we're really great Helen can join us. So to start with, I'm going to do our welcome to country that we do as part of being Macquarie University. I would like to acknowledge the traditional custodians of the land on which we are gathered and pay my respects to their elders, both past and present. I would like to extend that respect to all Aboriginal and Torres Strait Islander people here today. So, just a little bit of an update on our Alert program. We've had a very successful year of education events. Yesterday we held our Advanced Lymphatic Anatomy workshop with 25 participants, and we had our cadaver dissection that Professor Hiroswamy participated in, and we're very keen for any of you who really want to upskill yourself in the lymphatic anatomy to please register for one of our workshops for next year. Just a little bit of a date for World Lymphedema Day, as we know, is the 6th of March, and next year on the 5th of March we're going to be holding a public forum here in the evening. So you might even encourage your patients to attend, and we'll be advertising and promoting that event. We're also running our Level 1 accredited lymphedema training courses that you may wish to refer your colleagues to. And our first course for next year is in February. So starting the 7th of February for e-learning preparation, and then our face-to-face from the 12th of February. So it's a little bit earlier next year, so we really encourage people to register before Christmas. And we're holding the course this year, for our next course here on our facility at Macquarie University down in our physiotherapy laboratories. And also a little bit of a highlight, we have one of our very experienced therapists going off on maternity leave next year, and in the next week or two we will be advertising for a full-time lymphedema therapist position. So those of you who might like to come and join our team, if you're a trained lymphedema practitioner, keep an eye out. We will send it through our networks, but it might be something you might start thinking about in preparing your CV if you're interested. And also I just thought an interesting bit of information you may find worthwhile is that as of today we've actually had 20 scientific papers accepted or published in this year 2018 from our Alert team. So we're pretty pleased and proud of that, and that's across our whole team. And I only said to John earlier that our team has grown from 2 of us 6 years ago to now over 25 people across our education, research and treatment program. So we thank you for supporting our program, and by doing that, coming to these events, which we will continue to do because we get feedback from you. So let me introduce Vaughan Keeley. Before I do that, I've got 2 other slides that I'm not very good at moving forward. Those of you who have a LinkedIn profile, we're really wanting to increase awareness about our Alert education events and activities. So if you could follow our LinkedIn page to spread the word about lymphedema and what we're doing here at Macquarie. So you search for Alert at Macquarie University. If you want to write that down, take a photo, or we can send that out later on. And if you attended tonight's event by referral from a friend, or you found out about it but aren't currently on our database, we'd encourage you to have a look on our website, mqhealth.org.au alert, and there is a click-on item there to join our database so that you get notified about future activities and events that we're doing. Now I will introduce our guest speaker for the evening, Professor Vaughan Keeley. Vaughan Keeley is a consultant physician who works full-time in lymphedema. He leads the lymphedema service in Derby, Nottingham and Mansfield in the United Kingdom. Until recently, Vaughan was a member of the International Lymphedema Framework, the ILF board, and chair of the scientific committee. Vaughan chairs the British Lymphology Society Lymphedema Support Network Consensus Group, which has produced guidelines on the management of cellulitis in lymphedema. His research interests include the early detection and possible prevention of lymphedema in breast cancer, something dear to my heart, quality of life in lymphedema, edema in multiple sclerosis, and edema in obesity. Vaughan is also an honorary professor at the University of Nottingham Medical School. His talk tonight will be about cellulitis in lymphedema. Please welcome Vaughan.
Thank you, Louise, and thank you, everybody, for coming. I'm on holiday at the moment, and Louise came over to the UK earlier on in the year and said, "Oh, when you're next in Australia, come and see us." So I thought I would, and there's no such thing as a free lunch, so here I am. But I first came to Australia in 2009 to the ISL conference when in Sydney here. And that was an experience because we had the red fog that some of you may remember that appeared. And when I got up in the morning, it was really weird. So I thought I'd show you a holiday snap from, this is taken last week, of Kangaroo Island. I've got treated myself to a new camera lens, and I was playing around with it and had this fantastic opportunity. And so this is why I come to Australia. So, on to the topic. This is about cellulitis, and I'm sure most of you know what cellulitis is, but the literature is a little bit confusing because so many different names are used, and that always reflects that we don't fully understand a subject. So, in Europe, it's often called erysipelas. Technically, erysipelas is a very superficial infection of the skin, and cellulitis often describes a deeper infection. In lymphedema, we sometimes think people get inflammation, which isn't an infection, so the term acute inflammatory episodes came in a few years ago, but that seems to have gone out now, and most of us are using the term cellulitis to mean what I'm going to describe today. So it's a bacterial infection of the skin and subcutaneous tissues, and as we all know, it's more common in people who have lymphedema, and they can get recurrent episodes, which can be a real challenge for us clinically. How common is it? I thought I'd show you some of the results that we've had from the ILF project, the International Lymphedema Framework project called LymPrint. This is a multinational study looking at various aspects of lymphedema, particularly the impact and prevalence. That's what the LymPrint means, impact and prevalence, an international study of lymphedema. And we collected data. This particular set of data comes from patients attending specialist services. So a number of these are from the UK, but there's some from Canada, from, I think there are only Australian ones in this particular group, but there's various other countries around the world, Denmark, France, etc. And this was looking at patients who were attending specialist lymphedema services. So the main thing to see is, let's see if I can work the pointer here. This shows whether a patient has ever had cellulitis. So over 35% of patients on our books had at least one episode of cellulitis. And these are how many people had had an infection in the previous year. And you can see here the people who'd had more than one infection, so a significant number. This is a slightly more complicated figure, but it's basically looking at those with primary lymphedema and secondary lymphedema. So effectively, these are the primary lymphedema and these are secondary lymphedema. Basically, what it's showing is that both people with primary and secondary lymphedema get cellulitis, which is an important point. And this one looks at those who've had cellulitis and those who haven't against age. So these graphs are slightly difficult. When you're working with statisticians, they seem to be on a different planet from me, so they organise things in a way that I don't quite follow. But the percentages, if you look at the percentages, they add up to 100 for all the ones in blue, and the ones in red, they all add up to 100. The red ones add up to 100 as well. So this shows the population. And basically, the point of this is to see that cellulitis can occur at any age, including in children. And it's often one of the myths of cellulitis and lymphedema that children don't get it. They do. It's often not well recognised. Lymphedema in children is rare, but cellulitis can be a part of the problem. And as you can see, if you look at the blue graph compared with the red one, then the blue one has a shape which is slightly shifted to the left, suggesting it's more the people who have cellulitis tend to be the younger ones, interestingly. And then this next slide looks at, we've done the primary and secondary lymphedema, but if the one I wanted to just focus on is the one on the pair of histograms on the right, the cancer versus non-cancer. So again, in a slightly odd way, the people who have cellulitis, so the blue, 50+% and the 40-something% add up to the 100, and the right-hand lot, the less than 30% and the 70%, are the ones who don't have cellulitis. What you can see there is there's a preponderance in people who have cancer-related lymphedema, which is interesting. And whether that's, we don't know why this is a huge number of data sets, pieces of data in this data set. Interesting observations occur. We don't necessarily understand why. Whether this is related to immune problems for people with cancer or cancer treatment, I guess is a possibility. And then the other group, which we are becoming increasingly aware of, those of you working in lymphedema services will be only too aware that there's a growing incidence of lymphedema associated with obesity, and the obese patients, as you will see from the shapes of these graphs, are more likely to get cellulitis as well. So how does it present? Again, this is probably familiar stuff to you all. There's the classic presentation, which is of flu-like symptoms, aching, shivering, headache sometimes, vomiting sometimes, and fever usually. And then pain, redness, a rash, more swelling, warm area, tenderness, sometimes blistering, skin breakdown in the area of lymphedema. But the presentation can be very variable, and it can vary from person to person. Quite often in individuals, however, if they have recurrent cellulitis, they often have a very similar pattern, and I'm sure you've seen patients who will say to you, I know when my cellulitis is coming on, I feel a pain in the armpit, pain in the groin, I feel a particular feeling, and they know they're getting an episode, and that can be a really important opportunity for early intervention with antibiotics. So that's a significant factor to work on. So this is a classical picture of somebody with cellulitis of the upper part of the thigh. As you can see, they've been got at by somebody who's drawn a nice black line around the end of it, which is an important sign of cellulitis if somebody's seen them before. So this is, as you know, to mark whether the extent of the cellulitis and to see whether treatment's being effective. In other words, if the redness recedes from the line, you're on to a winner. If it's not, then you have to think again about the management. So. But this is to illustrate some of the differences that we do see in terms of the presentation. So this patient has cellulitis, as you can see, affecting the arm, but extending across the chest wall. I'd be interested, having been to the anatomy session yesterday, as to whether these are the areas of the dermal backflow that you might map out with ICG on that patient. But I just wonder whether that's... it struck me when I was looking at this slide earlier today. I've seen something similar in the pictures from the course yesterday. And this next one is the same patient on a different occasion when she had another episode of cellulitis. And as you can see, the rash is very different in its presentation there, but she was unwell and we treated this as cellulitis as well. So it can be very variable. Is it definitely cellulitis? That's one of the things, not so much in patients with arm swelling, but with people with leg swelling, particularly obese people. And there's always this question of so-called bilateral cellulitis in people with lymphedema of the legs. And knowing whether it really is cellulitis is quite important, A, from the point of view of treating the acute episode, but also more particularly if people are having recurrent episodes, we don't want them to get on prophylactic antibiotics unless they really do have problems with recurrent episodes of cellulitis. So it's a clinical diagnosis. There aren't any specific tests, as I'm sure you all know. We sometimes find certain tests useful. Certainly if people end up in hospital with cellulitis, they'll have their white count and CRP done, various other things. And swabs are usually not terribly helpful. I think blood cultures, if people have severe infections or in hospital and may have sepsis, they can be helpful in understanding which bacteria are involved. And then sometimes the anti-streptolysin O titer can be helpful. I think we use this in patients that come to us and say, oh, I keep having bouts of cellulitis, but you're not totally convinced because they don't seem to be that ill with them and their arm gets inflamed or the leg gets inflamed. And I sometimes do these tests just to reassure myself, and quite often these tests are all negative in that group of patients and their inflammation is due to something else rather than an infection. What else could it be? This is what we tend to, in the UK, call the red legs. And these are people who present with acutely red legs, usually both of them at the same time. And often that's a reflection of raised venous pressure, perhaps an acute lipodermatosclerosis. Sometimes these are people who are obese. They may become more immobile, and as a result of that, their dependency may cause an increase in venous pressure. But we do have to think of other things like a DVT or some eczema, dermatitis or contact sensitivity, which can cause an inflamed leg, usually without the systemic symptoms. So this is somebody with venous disease, as I'm sure you can all see, and this is the sort of leg that will get inflamed from time to time, and it won't necessarily be cellulitic. So what triggers an episode? Sometimes in people with lymphedema there can be a very obvious cause, a cut or a scratch, athlete's foot, skin problems like eczema, leg ulcers, all sorts of obvious areas where the skin is broken. But sometimes our patients say, well, I tend to get it at times of stress. I had one patient that worked in a department store, and in this time of the year, running up to Christmas, she would always get cellulitis when she was totally stressed out. And then we see quite a lot of people that say, I had a sore throat when this all started, and you just wonder whether the bacteria get in via a route like the throat and then find their way to the vulnerable area of where the lymphedema is. And then some people, there's just nothing obvious that explains that it just happens. How can we reduce the risk of getting it? These are all what in the UK we call the common sense approach to this problem of trying to avoid skin breaks, cuts and scratches, treating cuts and scratches with antiseptic cream early, managing any skin conditions like eczema, treating leakage, any lymphuria with compression to try and seal that up, and treating the lymphedema seems to help reduce the risk of getting cellulitis. So that treatment of lymphedema is quite interesting because we know from work done some years ago that the sort of compression treatments, CDT type of treatments as a combination, reduce the risk of cellulitis in patients with lymphedema. But it's interesting when you look at treatments like liposuction, LVA, these are all now being shown to also reduce the risk of cellulitis in people. So some way of managing the limb volume and improving the skin seems to be a common factor, I suspect. So why do people with lymphedema get cellulitis? And when I came into lymphedema, there was this idea that you had this fluid full of nice protein and the bacteria just went in there as a nice growth medium, and that was what caused it, but actually it's a bit more complicated than that. So we know from some of the research that there is an impaired local immune response in lymphedema. That's not too surprising because the lymphatics are a key part of our immune system. So if there is a slow flow in the lymphatics and abnormal pathways, then there may not be the same sort of rapid immune response to local infections mediated by the lymph nodes. In some of our patients, the rarer patients, I see quite a lot of people with rare conditions, and some of the rare primary types of lymphedema have immune problems as well. So in these group of patients, cellulitis can be a particular problem. And what's emerging, I think, more recently is that there are some of the particular features of the bacteria that may be playing a part in why the lymphatics are affected. And I thought just say a little bit about this. One of the main groups of bacteria that seems to be involved in cellulitis is the group A streptococci. And they have a capsule made of hyaluronan around them, and that's the capsule and presence of it and the type of capsule is one of the factors that determines how virulent the bacteria is. And if you look at lymphatic endothelial cells, they have various proteins and receptors on them, and there's one called a LIVE-1 receptor, which stands for lymphatic vessel 1 receptor, and that binds to the capsule of the bacteria, binds to that, so the bacteria naturally find their way to the lymphatics, and it may explain one of the reasons why the lymphatics are targeted by these particular bacteria and why we see cellulitis in people with lymphedema. How do we treat cellulitis? It's a bacterial infection, so antibiotics are usually required. Depending upon the severity, these can be oral antibiotics on an at-home basis, but some people require admission, or we have systems in the UK for outpatient antibiotic dosages given intravenously, and that's the main treatment. I'll come on to the details of that in a minute. Some of the other areas I just want to talk about are a little bit more controversial, so it's worth having a discussion. So remove compression temporarily. So we say this largely because the patients have already done it. It becomes painful, and so patients find it really difficult having their compression garments on, so they take it off. I raised this recently in our group which produces the cellulitis guidance, and we had a visitor from the Netherlands, and he said, "Oh, we treat our people with cellulitis with compression." I said, "But surely it's too painful." He said, "Well, we wait for that bit to settle down, and then we actually use more aggressive compression to try and treat it." And be interesting to see, they feel that helps the recovery, and it's one of those questions which some research on would be quite helpful. For many patients, pain relief is required. We've suggested paracetamol. There has been some evidence in the past, and I've now put this in brackets because I think we're taking it out of our guidance because the evidence isn't really very good, but there were some papers some years ago which suggested that patients who developed a more severe form of cellulitis, necrotizing fasciitis, so that's where the infection goes deep into the muscle areas, that they were more likely to get it if they'd been taking non-steroidal anti-inflammatory drugs such as ibuprofen. It was very soft evidence, and I don't think there's been any other evidence since. And those of you who've been involved with some of the work looking at the use of non-steroidals in treating lymphedema or derivatives of non-steroidals, this would be a bit worrying, but I think there seems to be no evidence now that's emerged since those early papers, so I think we can be more relaxed about the use of these. We certainly don't want people who are on regular non-steroidals to treat their arthritis or whatever condition to have to stop them while they've got cellulitis, but I guess if you were to choose between ibuprofen and paracetamol, maybe paracetamol would be the first choice. And then there's a debate about whether resting the limb is important. Anecdotally, we sometimes see people whose cellulitis seems to linger until they actually stop running around and rest up, and then it settles down. So one of the things, as Louise has mentioned, is I've been involved with this group of the British Lymphology Society and the Lymphedema Support Network for some years now. Anita Wallace, who's the chair of the Lymphedema Support Network, they found that the members of their group, which is a patient group in the UK, were having huge difficulty when they went to their general practitioners, getting them to recognise cellulitis and to know how to treat it when they had lymphedema. And she is I don't know whether people know Anita, she's a very strong character, and she, I always tell the same story, so she knows this. She locked several of us into a room and said, "Come up with some guidelines now." I exaggerate slightly. But she managed to get us together. We had a multidisciplinary group of doctors, nurses, therapists, and even at some stages managed to get some microbiologists involved to look at the existing evidence and to draw up some consensus guidelines, which we've done since 2005. And each year fortunate we have a clinical librarian who does a literature search for us on the latest literature on cellulitis, and we amend our guidelines accordingly. Unfortunately, there's not a lot of research goes on, so they don't have to get changed very often, but sometimes new things arise which help with our decision making. And so this is a shared consensus group with the British Lymphology Society and the patient group, and we have got some evidence. I won't go through it today because there isn't really time, but we've got some evidence that the behaviour of people treating cellulitis, in other words, general practitioners, has changed since we did this. We did a small audit when we first set them out in about 2008, and then we did another one several years later, and the number of people who were having antibiotic prophylaxis had increased. The duration of the course of antibiotics had increased. They were being given too short doses originally. So we think there's some soft evidence that these have had some effect. Why is it a consensus document? Well, it's because there's no real strong, high-quality evidence to say how we should treat these things, and there's different views on the management and even different views on which bacteria cause the problem. A Cochrane review done a long time ago now, in 2010, just concluded they couldn't define what the best treatment was, and it hasn't really changed a lot since then. Our approach was to think about which we thought was the most important organism, therefore which antibiotics should we be using to treat that, how long the course of antibiotics should be for, and whether there was a difference in the way the antibiotics got into lymphodematous tissue compared with ordinary tissue if you didn't have lymphedema. And if you look at the microbiology, again, this was done as part of the Cochrane review. As we all know, getting positive samples anywhere to see which bacteria the cause is really difficult. In their particular review, 25% of patients admitted to hospital with cellulitis had positive cultures, usually from blood cultures. If you're bold enough to do skin biopsies, which aren't done routinely, you can increase that, and it's the beta hemolytic streptococci that seem to be the main cause. And they concluded that staphylococci were probably not the cause of classical erysipelas, but sometimes cause cellulitis. So this is the distinction they're using of the erysipelas as more superficial infection than cellulitis. I think there's still microbiologists, certainly in our hospital and around, that think staphylococci play a really important part in this, and so recommend antibiotics that kill both streptococci and staphylococci as the main ones to use. So this is the debate about flucloxacillin versus amoxicillin. Flucloxacillin is anti-staphylococcal and anti-streptococcal, but amoxicillin is anti-streptococcal alone and doesn't do anything for modern staphylococci. Tissue penetration, in other words, getting into the lymphodematous tissue, is probably better with the amoxicillin, and the side effect profile is similar. We've, in our guidance, tended to suggest that amoxicillin is the better antibiotic. Having said that, if there are any signs of staphylococcal infections, such as crusted dermatitis or folliculitis, then we would recommend flucloxacillin. But in the UK, general practitioners use flucloxacillin. That's what they've been taught to use by the local microbiology guidelines, and so we've included that in our guidance. It is not a wrong antibiotic to use. We didn't want patients to go along to their GP and say, no, you shouldn't be using this, you should be using amoxicillin. And flucloxacillin is something that seems to work for most people as well. There's always this issue of drug resistance to consider, and again, I'm not sure whether you've got the same resistance here as we have now, but there are streptococci that are resistant to clindamycin and erythromycin and tetracycline, but so far not the penicillins up to present. Is that similar here? Yeah. So our conclusion was that we preferred amoxicillin as our first-line antibiotic, but flucloxacillin was acceptable. So in the guidance, and I won't go through the guidance in huge detail, I'll put the web link up at the end, was that as for a standard, relatively straightforward episode of cellulitis which didn't require hospital admission, that oral amoxicillin for at least 2 weeks was the treatment of choice. The evidence for the duration is not in the literature, really. This is mostly based on a lot of shared experience, I think, and you've probably seen it as well. People who have a course of 1 week of antibiotics for cellulitis in their lymphedema, it often gets better and then recurs about 3 or 4 weeks later. And that pattern is something we see from time to time, well, quite frequently. And those who have 2 weeks, they seem to have less chance of getting it back. It's anecdotal rather than based on a lot of evidence, but I think we've all been convinced by it over the years. So why is cellulitis a problem? The acute infections can be quite unpleasant. Sometimes you can end up with sepsis and be really significantly ill. We've had a few of our patients on high dependency unit and things with renal failure and problems. There's less severe problems and loss of time at work. But we also recognise that cellulitis damages the lymphatics and therefore makes the lymphedema worse. And because recurrent episodes are common in people with lymphedema, then recurrent episodes damaging the lymphatics further and causing worsening of the lymphedema is something we want to try and avoid. So recurrent cellulitis is one of the things I really want to focus on because it's one of the big problems that we face in lymphedema. We did a survey. This was our first survey of patients with cellulitis. So this was a survey, it was just a paper survey that was sent out via the Lymphedema Support Network. So the patients who were members of that group, and there were people who had an episode of cellulitis in the recent past, and they were asked to respond in respect to that episode. But we also asked them had they had episodes before, and 76% had episodes before. So it's a common issue. Obviously, people who have had lots of episodes of cellulitis are more likely to fill in our form, but having said that, these are significant numbers, and they averaged 1.8 episodes per year in this group. There was a more recent Cochrane review in 2017 looking at interventions to prevent recurrent cellulitis. So this was not just in people with lymphedema, but when you look at it, people with lymphedema are likely to be those with recurrent cellulitis. And equally, I think a lot of us are now saying if people are getting recurrent cellulitis, they've probably got a lymphatic problem. So we have to think of it that way around as well. So this is a typical Cochrane wordiness, and I've left it in Cochrane wordiness. And so in terms of recurrence, incidence, time to next episode, antibiotic is probably an effective preventive treatment for recurrent cellulitis of the lower limbs in those under prophylactic treatment compared with placebo or no treatment, moderate certainty of evidence. That's amazing for anything to do with lymphedema to have that degree of evidence. And it was largely based on one major study which was done in the UK, which I wasn't a co-investigator, but we contributed patients to this study. It was group based in Nottingham, so it's the UK Dermatology Clinical Trials Network, and was published in the New England Journal of Medicine. And it was a randomised controlled trial of prophylactic penicillin for the prevention of cellulitis of the leg in people who'd had at least 2 episodes. So these weren't necessarily people with lymphedema, although obviously a significant number of them did have lymphedema. There were 274 people in the study, and they were randomised to receive phenoxymethyl penicillin, 250 milligrams twice daily, or placebo for 12 months. And they were followed up for 3 years, and the primary outcome was time to first recurrence. The reason for going through this is I think it has a lot of useful information in it. At the end of the treatment, the penicillin group had a 45% reduced risk of recurrence, so that was good. That's the positive result. It did mean it wasn't abolished altogether, so we'll come back to that. That effect wasn't sustained beyond 12 months once the treatment had been discontinued. So once they stopped the penicillin, then gradually their risk of cellulitis came back. And by the time you got to 3 years, it was the same as it was to start with, which is a bit worrying. Interestingly, and I use this a lot in discussing with patients, the side effect profiles were similar in both groups, and that included things like thrush. So the people who had the placebo had the same incidence of thrush as those who had penicillin, because a lot of people think all antibiotics will give me thrush or other problems. And what was interesting, the side effect profiles were the same in both groups. So back to these people that still got the cellulitis, 22% still experience repeat episodes of cellulitis. When you looked at that, they tended to be people who had a high BMI of greater than 33, and also people with edema. So it fits in with what we were saying earlier. People with a high BMI are probably more prone to cellulitis, and people with lymphedema are more prone to cellulitis. So it raises issues about our need to manage these problems. And I don't know whether she's in the audience. Where's our person that's doing the RCT on this? Yes, there you are. Hello, yes. You're looking at this issue of managing the edema. That's right, isn't it?
Yeah, a randomised controlled trial looking at if we do manage edema, do we prevent the cellulitis?
Yeah.
But 60% have a BMI over 40 in
Yeah.
the study, so most people are very heavy. We've only got one person out of 80 in the healthy weight range.
Right. So a challenge, but this is real world. This is real world stuff. This is what we're seeing. So yeah. So I think. Sorry, going back. I think that's a really important study, and I think it raises all sorts of useful points for us. So we've based some of our other advice and guidance on the outcomes of that study. One of the things that has come up to us recently, and we hadn't really taken this into account in our guidance, because I was at one of our hospital grand rounds, and they talked about antibiotic stewardship and the WHO classification, which I have to confess I hadn't come across until very recently. And these are how antibiotics should be considered in terms of whether we can use them or whether we need to be cautious about using them. So there are three sorts: access, watch and reserve. And the access are key antibiotics. The WHO feels these should be available in different countries to treat infections. Unfortunately, our friends amoxicillin, flucloxacillin and phenoxymethylpenicillin are part of this. One of the antibiotics that's used quite a lot for outpatient intravenous treatment of cellulitis in the UK is ceftriaxone. I don't know if it's the same here, but that's one that's used in the UK. Those that we have to watch are those that they have a higher resistance potential, and so they feel they're targets for monitoring whether we should be using them. And interestingly, I've just put some examples. There are loads of others in the list on the WHO site, which if you're interested you can see. But one of the ones that's particularly important for us are the macrolides, which we tend to use for treating cellulitis in people who are allergic to penicillin. And those are a problem area. And interestingly, our friend ceftriaxone appears on this list as well. So some of the antibiotics appear on both lists where there is concern in certain circumstances. And then the reserve group, these are sort of last resort antibiotics which we should be using sparingly, and particularly fourth and fifth generations, cephalosporins, and daptomycin, Nesolid, and loads of others. But I noticed some of our patients with severe cellulitis are being treated in hospital with daptomycin, I've seen recently. So I think we just have to think about this in relation to our consensus document, and we're going to be doing this. So this isn't included in the latest version that we have. The other problem is Clostridium difficile infections with antibiotics, particularly things like clindamycin, cefalexin. And this also raises issues if we're looking at recurrent cellulitis and what sort of antibiotics we should use as prophylaxis. So our current thinking is if people have recurrent episodes of cellulitis, in other words, 2 or more episodes in a year, we, and I've underlined, consider antibiotic prophylaxis. So this is doesn't mean it's an automatic knee-jerk write a prescription response. I think it's important that we weigh up all sorts of other factors as well. So these are the things that I think we feel we should consider. Is it really cellulitis? We've discussed that earlier. If it isn't, then antibiotic prophylaxis are not important. Can we reduce the risk of getting more cellulitis with other non-antibiotic measures? which is managing skin conditions and skin care, but also, as we've mentioned earlier, reducing limb volume, treating the lymphedema, which hopefully your study may help us with. I think hopefully it will show the result that we expect, which will be a positive one. What we sometimes do now, if people are having lots of problems with cellulitis, is to put them on prophylaxis for a year at the same time as managing their lymphedema and their skin conditions, so that hopefully we can reduce their risks while we're treating them, and by the end of the year maybe we can take them off the antibiotics. But we have a big problem about those who are allergic to penicillin. The evidence that you've seen from the UK trial is based on penicillin. If people are allergic to penicillin, then we run into more problems. The balance of the pros and cons is much more difficult. Things like the macrolides, they can interact with drugs that everybody seems to be taking, the statins, so that can be an issue. And then there are issues about the antibiotic stewardship that we talked about just now, and the risks of C. diff for other antibiotics that you might use. The other thing we consider is the site of the cellulitis. For most cellulitis, such as in the arm and leg, then what we've just said is perfectly reasonable. Where we find that those things like penicillin fail, often in people with genital lymphedema and cellulitis associated with that, and we end up using other antibiotics such as trimethoprim as prophylaxis in that group, and that sometimes seems to be successful. So these are guidelines, not rules. They need to be adapted to individual circumstances, and I think for prophylaxis we need to be very thoughtful before we start it, rather than it being a knee-jerk reaction if people have had 2 episodes of cellulitis. Improving control of the lymphedema and skin conditions, I think, is important. And what we sometimes do for patients who we are nervous about giving prophylaxis to is make sure they have a course of antibiotics at home, a 2-week course of whatever antibiotic they can take if they're allergic to penicillin, so that they can take it promptly if they get the symptoms that they recognise as cellulitis, and that may be another way of managing it. So that's the main bit on the guidance. I just thought if I've got time to just talk a little bit more about a research prioritisation exercise which I was involved in. As you know from the Cochrane reviews, that we've still got very little evidence here, and the UK Dermatology Clinical Trials Network organised a group of us to look at what were the research questions that were important in cellulitis that should be asked. There is a system, I don't know whether, again, it's something you use in Australia, but it's a thing called the James Lind Alliance, which has been in the UK, who developed a methodology for looking at research prioritisation. And this is proving to be quite an important area, because the research funding bodies are now looking at these lists. So they will say, if you want to do a project, where does this come on the James Lind Alliance research prioritisation exercise for your topic? And so they're becoming increasingly used tools. So I was involved with this, as well, other members of the BLS and the Lymphedema Support Network. And I won't go through this in huge detail because it's quite a complex, laborious process, but basically you start with a literature review to make sure that you're not asking a question that's already been answered. You then carry out a survey monkey of various interested parties, stakeholders, which are basically asking, what do you think are the 3 most important questions in terms of research questions in the area? And we focused on questions specific to diagnosis and management rather than anything to do with cellulitis. And then you get a whole load of things back, and those are then grouped into broad themes, and those are reduced down. You send it out again and get people to sort of prioritise those. And then there's a final group which gets together, and in our case we had representatives from the research funding bodies as observers, which was really important and interesting to the government research funding body. To look at the process and what we were coming up with. And the main message from this is the characteristics of who took part in terms of respondents. 41% were patients and 54% professionals. I think that's really healthy. Inevitably, most of the patients are people with lymphedema, because this was about recurrent cellulitis, so a group that is very keen on getting some answers to the problem. And these are the top 5 questions. I thought you'd be just interested to see them. So first one is, how can healthcare professionals be best supported to accurately diagnose and manage cellulitis and advise their patients in how to prevent relapses? There was a strong message coming over from patients that they were still concerned that healthcare professionals didn't really know enough about cellulitis and how to manage it confidently, and this was where the be best supported came in, I think. Which are the best diagnostic criteria? Are they different for different patient groups? Is lymphedema cellulitis different from other cellulitis? When treating cellulitis, could a higher initial dose or longer course of antibiotics result in a faster recovery or fewer relapses? That's something that I think would be a really useful thing to have some proper evidence for. What's the best non-antibiotic intervention for prevention of cellulitis? And then a whole list of things like skin care, managing athlete's foot, using compression treatments and such like, which again your project would come in under this category. And does rest and elevation during episodes of cellulitis help to speed up recovery and improve symptoms compared to mobilising? There are lots more questions. I just thought we'd look at the top 5 just to give you a flavour. If you're interested in it, it was published, it's just a research letter, but it's got all the questions in and a brief description of the methodology. Kim Thomas is the lead author and published in the British Journal of Dermatology. So what do we hope happens from that? Well, the questions are obviously now out there, and the research funders are looking at things. We've had some interest from one of the government research funding bodies, and they've done a bit of a look at, they've asked some of us to comment on a research proposal. It hasn't been put out for applications for grants yet, but something's happening still, so it's encouraging. This may take things forward. And one of the sort of, I think, unexpected side effects, if you like, of this was that it got together a group of patients and healthcare professionals who were interested in conducting and contributing research. Some of our patients took part, and they really found it helpful to be involved. And I think when we're looking back, if there is a project that comes out of this, that having a group that's already there, including patient representatives, will be very strong in terms of taking it forward. These are my colleagues that have taken part in the various groups. Katie Riches, many of you may have come across, our research nurse who guides all these things, and Lisa, who's our librarian, who helps us with the annual literature review. And that's the website where the documents can be found, either the BLS one or the Lymphedema Support Network one. Thank you very much.
For that excellent presentation. We have now got time for questions, so if you've got a question, please put your hand up and we'll bring the microphone.
Well, thank you, that's fantastic. At a conference at the ALA, I went to a fascinating wound care session, and one of the speakers was talking about a betadine bath. We should all have a betadine bath once a week. And it's sort of, spoke about the trillions of bugs we've got in our body, and you mentioned the antiseptics. Has there been any research on that type of thing?
Not that I'm aware of. The only thing that I think has been done is, maybe aware of Terence Ryan and work in India and places with Dr. Narahari, particularly in the Institute in Kerala, where they've looked at simple hygiene of soap and water washing, which obviously may not always be easy in tropical countries, but those do seem to have an impact. And I'm not sure the hygiene in a number of our patients in the UK is as good as it could be, and I think some simple measures of soap and water washing and drying could be just as effective, I suspect, rather than the antiseptics.
And sorry, just one more. In the 22% who are on prophylactic antibiotics who relapse, what's your treatment strategy for that group?
So, yeah, that's a difficult one. I think we do look to see if there's any thing we've missed in terms of management of their edema or any skin conditions or such like. Sometimes we change the antibiotic prophylaxis, but that's something I'm not wouldn't rush to do. In other situations, we do come across people where they just have a proneness to it. We've even had 1 or 2 people who've had loads of cellulitis who've been penicillin allergic, and we've got one person in particular that we've had desensitised to penicillin so that we could use the penicillin, and that seems to have made a difference to it. And sometimes with our more complicated patients, I've gone back through all the sensitivities of anything that's been grown from the bacteria cultures, and just to see if there's any strange organisms. So I guess the most common unusual thing is where we've had people who've had perhaps a more complex primary type of lymphedema where they've got leg swelling but some genital swelling as well, or those after with cancer-related lymphedema. And in that case, it's not always the streptococci that are the problem. So thinking about the other the other bacteria and other antibiotic prophylaxis like the trimethoprim, and that sometimes made a difference and has broken into the cycle of recurrence in some patients.
So if they recur, do you go to a full dose of amoxicillin, or do you stop that and give them Fluclox?
Oh, I see.
Yeah.
After an acute infection,
Yeah.
you mean?
So
Well,
they're on prophylactic amoxil, and then they get a flare up.
Yeah. So if they're on prophylactic penicillin, then they get a flare-up. They may be the sort of people that have antibiotics at home, so they'll have a course of amoxicillin or flucloxacillin for 2 weeks. Sometimes the difficult ones, we prolong that course, or they end up having intravenous antibiotics. There are techniques like that which sometimes you feel that the original infection hasn't been fully cleared. If you talk to Peter Mortimer, he thinks the infections are never fully cleared, and that maybe we're just sort of on the tip of the iceberg, really. So I think there are manoeuvres like that that we would use to try and get on top of it. Yeah.
I was wondering about intramuscular versus oral, what your thoughts were about that with antibiotic treatment.
As prophylaxis, yes. In bits of other parts of Europe, I'm not sure we are still part of Europe at the moment, but the intramuscular benzathine penicillin has been really quite popular. I don't think British patients like intramuscular injections very much. I don't think, to be honest, I don't think there's any evidence that shows that one is better than the other, but there is a lot of belief in certain parts of Europe that it has to be intramuscular. So yeah, I'm not aware of any evidence that shows it.
I feel like the meanest person in the world when I do give it, so, you know.
Vaughan, how many of your patients actually get admitted to hospital? You have to be very sick to get admitted with cellulitis and lymphedema?
Yeah. It's interesting because as a lymphedema service, we don't actually see the cellulitis much because they go in through the A&E departments or they go in under acute medicine. We occasionally, patients will come to our clinic and they happen to have had an appointment. They've got an acute episode of cellulitis, so we will treat those. So I can't really give you the percentages, but I think increasing numbers of people are managed at home with it because of earlier recognition, but some patients just have cellulitis that means every time they get it they end up in hospital because they just have that rapidly progressive sort. And you've probably seen these as you're working in lymphedema clinics, that there's some patients where they can be well 1 minute and then half an hour later they can be really poorly and end up in hospital, and it can be really quite scary. The trick for them is when they attend hospital, people look at them and think, oh, you look fine to me, go home again. And we've had problems where we've had to give them effectively an arrangement with the hospital, an arrangement the patient holds, this is what I need to have when I'm ill, or arrangement with a particular ward. It's rare, but there are some patients that get very ill very quickly. So I think probably, without the data, I would imagine most people are managed with oral antibiotics at home. An increasing number that are managed with an outpatient course of intravenous antibiotics, and there are a smaller group that get admitted with sepsis. Yeah.
Just interested with the imprint system. We did a registry of people, about 1,500 went it, and what we found was that cellulitis episodes in arms were less than legs, and of course women less than men, because men don't get very many arms. And our percentage of people who'd had a episode of cellulitis, which was described as cellulitis requiring antibiotics, was up to 70% if they'd had they were more than 10 years in. So the percentages kept on going up.
Yeah.
And I guess the thing that concerns me is these are people who actually probably treated lymphedema patients. I mean, we're not talking about people who answer surveys generally have a diagnosis and have garments on, and it still was very high.
Yep.
It's interesting that there was still a very small percentage who really clearly presented the initial presentation of lymphedema was this episode of cellulitis.
I agree. I don't think we get it right all the time just with managing it. I think there was some interesting work done when lymphedema services were introduced. Christine Moffat did a study in Wandsworth in the UK, and one of the measures they looked at to see the effectiveness of lymphedema services was whether there was a reduction in the incidence of cellulitis. And in the paper that's been published relatively recently, it dropped to virtually zero following the introduction of service. I'm not sure zero is always a worrying number in this sort of setting, and I certainly see a lot of patients that, despite all our best endeavours, still get recurrent cellulitis. But also, I probably could say, despite our best endeavours, their lymphedema is probably not totally managed, in terms of the control of the volume for all sorts of reasons. And I think the other factor that I've become increasingly worried about, and I think it's a limitation of the Limprint study, although hopefully people who are coming to specialist services it will be more accurate, is whether it's been really cellulitis, because I think there are a lot of people that we see in our clinics with chronic venous disease and particularly the obese patients who get the bilateral red legs and do get put on antibiotics. So even that definition isn't foolproof for them, when I've gone through things, I think, well, I'm not sure this is really cellulitis, and therefore wouldn't put them on prophylaxis. So I'm sure you're right, Helen. I don't think we get it right all the time, but I think I suspect your study will show an improvement, as has previous things, really. Yeah.
There was a streptococcus vaccination coming through.
Not that
it's probably in. I heard it on the internet, so it must
all right. I don't know. That would be interesting. Yes. It's whether it works in people with lymphedema. That's been another interesting question.
Other questions for Vaughan?
I do have one if there's not one. This might be an annoying question, but it was the worst case of a client that had recurrent bouts of cellulitis, secondary arm lymphedema. Her presentation looked similar to the picture that you showed of a very swollen arm post-mastectomy. She had a portacath in situ, not because she was undergoing chemo, but because the local hospital couldn't cope with how many times she was going in. And as a lymphedema therapist, I guess pharmacological management is outside our scope of practice, but I guess this has made me think maybe as a lymphedema therapist, so it's a double-barreled question, should we be more aware of what the pharmacological management should be so that we can assess whether we think that patient maybe needs to follow up? Because this client had recurrent bouts, and no matter what I did with her, it felt hopeless. She was in very good garments. We were trying our best to manage her, but we'd get her to do mild exercise, she'd have a flare-up. She'd be stressed at work, she'd have a flare-up. So it was a sort of hopeless case where I felt I was following best practice guidelines and trying to do the best I could, but...
I think you're right. I think depending upon our local setup in the UK, if they're part of our service, these are the folks that our therapist will get me to see, or one of my medical colleagues, because that's our sort of pathway within the system. Other services which don't have medical input, they would tend to use our guidelines and write a letter to the general practitioners asking them to consider antibiotic prophylaxis and such like, or to have a look at the whole thing, or they'll find their way to infectious diseases doctors sometimes because of the recurrent episode. So I do think it's important for lymphedema therapists to have an awareness and to point people in the right direction. Yeah, I agree with that. Thank you.
And then another question that we commonly get asked from students is, in terms of histological changes, is there any evidence that we should be referring to? We often get asked, Louise always jokes with me, I love the revised Starling principle and how glycocalyx is the semi-permeable layer, and they generally talk about the fact that inflammation damages that layer and therefore we can have greater influx. And one of our students raised that, is this why it gradually gets worse, that we have recurrent bouts of inflammation that damages that layer, therefore in terms of permeability we with chronic inflammation there can be more general flux of edema, and therefore...
I think it's probably 2 stages. I think what you may be seeing acutely is why you get acute swelling because of the inflammation and the increased blood flow. So people with cellulitis, their limb will swell acutely, won't it? So that's probably the local changes in permeability there that are driving that, and the change in blood flow. The chronic thing, I'm not sure whether we really know, but my suspicion, but the received wisdom perhaps I should say, is that the lymphatics themselves start to get damaged and will fibrose, and we'll see the same sort of pictures that we've seen that Hiru showed us yesterday with that narrowing of the lymphatics and damage over time. I suspect that's what we're seeing as well, although I'm not sure there's a lot of evidence out there. I don't know whether anybody else has seen it. No. Thank you.
Can I just suggest, what is the take-home messages from this talk today highlighting management of cellulitis for us as lymphedema practitioners? Is there anything that you're going to change in the way you educate your patients, what you tell them to do or not to do, to help in prevention and or management?
We are currently attempting to deal with people who have BMIs over 40 and recurrent cellulitis because of we have a 15% readmission rate over the last 4 years, and so what we're attempting to do is a multidisciplinary approach. But what we realise is that early intervention around cellulitis before the first episode is the key, from what you're saying and from the literature that we're reviewing. And what a lot of our people are coming too late. They're coming with lymphorrhea and wounds, and that's how we're discovering them. And so that's way too late. And they've already been into hospital twice a year for the past 5 years. So that's my take-home message that you've reinforced for us as an MDT in our clinics. We've got to get in early and talk to the physicians about how do we stop the first episode.
Thanks, Leanne. Any other messages? Things that you're going to change when you leave here tonight?
I'll just say I'm going to try to pay attention a little bit more to what pharmacological management is, because I'll say that as a physio, normally I read about antibiotic therapy and I've never really paid attention to it, so I'll be honest and say this has highlighted to me more awareness about that.
Great. Good. And I think too, just for me, just the education that we give to our patients, and this is one of my little pet things, but I think we need to educate our patients, but just not a one-off on the first visit we see them. It needs to be this drip filter approach to educating our patients, because they're only going to take in a certain amount of information each time they come, and if you're coming and going to give them the whole list of things to do to prevent or manage their lymphedema, we need to continually give that information.
Can I just add something to that? Because I think that you've just raised an important point about patient education. I don't know what it's the same here, but in the UK, a lot of our patients don't want to worry doctors and health services at the weekends. And one of the things I usually discuss with patients is if you're getting cellulitis, and it will always happen on a Saturday or Sunday, don't wait till the Monday to get it treated. And it is perfectly legitimate to seek medical advice at the weekend to treat it. And I think that's something that we routinely try to reinforce to our patients.
It's fantastic that so many of you have come after work today to hear our education event. Everybody attention, come on, I knew I shouldn't have let you go. Now for the last part of our evening tonight, it's going to be a short presentation by our one and only Dr. Helen Mackie. Helen is our clinical lead, rehabilitation specialist, and I think Australian guru of lymphedema management, and we're really pleased and fortunate to have her expertise. I said earlier today that Vaughan's the Helen Mackie of the UK. So we have the UK and Australian godparents of lymphedema with us, which is wonderful. But Helen is at a stage of her career that she just is committed to lymphedema, not only the clinical management of lymphedema, but also improving outcomes for people living with lymphedema and at risk, including cellulitis, but also in the advocacy area. Helen's the guru of meeting politicians at the moment and really trying to get better outcomes for us as health professionals in the lobbying for provider numbers and all sorts of things. So can I welcome Helen to give her advocacy update.
Okay, so I'm just going to go through some of the activities that have been happening over the last few years. One of the problems in Australia that England doesn't face, you have elections every 5 years, we have them every year, and usually sometimes twice a year. This causes it's very difficult in advocacy when you're talking to politicians, because the best thing they can do if you really get under their skin is they just retire or leave or get bumped off and so on. So the Lymphedema Action Alliance is a group that formed in about 2013, and Deb down there was a leading force in this, and it was a group of 20 organisations, which includes Alert, Country Women's Association, Cancer Council New South Wales, BNCA, which is the Breast Cancer Network Australia, Swell Kids, and quite a number of other groups. And really it was formed to be a more effective voice for the improvements to lymphedema. Louise and I had gone up to the New South Wales Parliament and had our little talk as well. But it was quite clear that when you're one-off, and particularly a therapy group, there's a lot of suspicion about your agendas and so on. So we formed this group. We did a meeting where we looked at a survey which had been undertaken through the ILFA, similar to the stakeholder survey, develop what are the things that people wanted, and these were the two actions that we came up with finally. Equitable access to lymphedema services in New South Wales. It was originally a New South Wales group, and sustainable access to affordable lymphedema garments nationally. So these are the 20 groups you see there, and when we go and talk to the politicians, we say we are merely representatives of more than 150,000 people who are all members of the organisation. Very helpful when you have the Country Women's Association, because they have loads of them. The International Lymphedema Framework is represented by Karen Tutt, and the Australian framework is actually folded, and the LAA is taking over some of that role, or in a way. So what we've done is we've written a number of briefing papers, and we've been very happy. The Cancer Council New South Wales is fantastic at writing these sorts of things. For both the election in 2015 and 2019, in March 23rd, we have websites. We're meeting with members of parliaments, both chambers, and we've written. We were told to go and write to all the area health services, so we did. We wrote to all the chairs of the board of all these and said, according to your statement of intent. You were supposed to provide excellent health services. What about lymphedema? And they all wrote back to the Minister of Health and said these strange people are hassling us. We went with the Minister of Health, Gillian Skinner, 3 times, and she sent us through to the Agency of Clinical Innovation, and we'll talk about this later, and we did a lot of work there. She then resigned and we had to restart again. We have met with the new Minister of Health, and just recently, rather strange and interesting meeting. We were informed by him at the end of the things that he didn't really like doctors, particularly as he divorced his GP wife some 8 years ago. Which was a little bit. So anyway, that be that as may, he called for a cost-benefit analysis before he would publish this document, which again I'm talking about it. However, he did reveal that there was 19.2 lymphedema practitioners working in New South Wales only, and we're not sure even if they're full-time equivalent, which is a very low number. HETI, which is the Health Department Education, continues to provide an online lymphedema awareness program for allied health in practitioners in the Department of Health, and as you can see, they've actually funded quite a number of lymphedema practitioners who've been trained by Alert through the last years, and we really would love these people to be actually active. So we're now undertaking some election planning, and this is in alignment with the Cancer Council New South Wales campaign. So this is the guideline to clinical services, which was written through the Agency of Clinical Innovations in their Chronic Care Network group. And it specifies principles of care within the public health system, and it was to guide local health districts in New South Wales to improve areas, and also written as a self-assessment tool for those health services. It's a great document, but they won't publish it until they had an implementation forum, and then they won't publish it until they've got a cost-benefit analysis to see if it's worth their while actually doing these things. Because it does cost money, they want to know whether they're going to get some sort of benefit from it. So these are the areas of the principles. As you can see, early intervention work, and you can see principle 6 was effective management of cellulitis. I wrote about an 8-page epistle with all sorts of things, which was reduced down to about 2.5 pages, but nevertheless. And it'd be fantastic if this was actually published. Cancer Council New South Wales set out a program. They do it every year when they come around to the elections to look at election priorities, and they do a stakeholder survey on that through CANACT. And these were the 3 priorities, and as you can see, supporting people with lymphedema. And the Cancer Council have been fabulous because they haven't actually excluded non-cancer lymphedema. They haven't kind of... They're talking about cancer-related lymphedema, but they haven't excluded that from their talk. And we have been told that lymphedema is getting the best traction with the politicians. So they have a wonderful video, and they have great network of advocates all throughout New South Wales who are prepared to go up to the local politician and talk about it. So we're just emphasising lack of management services. So we're hoping that this will be guidance. The LAA is working kind of in parallel with them. We're asking for funded services. They're asking for just improved services. So a little bit different there. And this is one of their part of their publications, and you can see that's they're talking about, and that's in a booklet. But part of the issues that we realised when we started to look at why the New South Wales or the Department of Health aren't interested in lymphedema is to do with diagnostic-related groups. Now, this is a statistical system for classifying people's stay for the purpose of a payment. And the Commonwealth Government pays a certain amount on to the state government, health departments, for the management of particular diseases. And when we looked at where lymphedema won, it was classified as a disorder of the skin, subcutaneous and tissue and breast, which was okay, except that lymphedema itself was classified as a minor skin disorder and had an extremely low weighting. So what happens is the Independent Hospital Pricing Commission gets together each year and it establishes what they call a national efficient price, which is then scored, and then you pay on the weighting to that particular payment. And the payment for breast-related lymphedema was at this level, a weight of 0.2, and lymphedema associated with cellulitis had a higher weighting. And so all this statistics available, and what happens is, say, if you've got a heart attack, of course you've had a much higher weighting quite naturally. But the fact that lymphedema was classified at such a low level meant that it was not really something that paid or allowed for payments coming into it. However, cellulitis itself is now the number one preventable condition admitted via public hospital emergency departments, and that was told to us by the Minister of Health. And that is really the hook to which we're advocating the actual trying to get management of lymphedema actually dealt with better in relationship to reducing this. So here we are. What happened was most lymphedema in public hospitals, I'm talking all about public hospitals, is treated as an outpatient treatment. And what happened when they went into DRGs, they left all the outpatient treatments on its own, so everybody's sort of mixed up together. So the Independent Housing Pricing Commission did a public... They decided they were going to reclassify the Australian Non-Admitted Care Classification Development, Tier 2 outpatient clinics. And they had a public consultation, and I luckily heard of it, and we went in and had a look to see where lymphedema was, and it wasn't. There was no classification for lymphedema. So what we did was we decided that what we tried to do is get lymphedema classified within. They don't treat skin diseases. So we tried to get it within the classification of as a circulatory disorder, because that put it in the same group as wound management clinics. So this is what we've recommended. So that was another little bit of work. It's gone into the system, and hopefully it will emerge again. Now, the next area of activity is mainly through the Australian Lymphology Association, which is a submission to the Medical Services Advisory Committee, MSAC, which is an independent, non-statutory, I don't know what that means, committee established by the Commonwealth Government, the Minister of Health, and it appraises all new medical services and provides and reviews all these surgical ones that they're trying to get rid of, and radiotherapy and so on. So they've gone through a huge review of all these item numbers and tried to get rid of as many as possible. But basically, this is the system you have to use to get an item number under Medicare. And so what we've done is the ALA has made a submission to this services committee, and John is one of our supporters and has helped us in the preparation of the document, which is quite difficult. Again, relies a lot on health economist data, for which there is very little. And really the submission was the provision of one-to-one complex lymphedema therapy to a patient with lymphedema by an APRA registered lymphedema practitioner for up to 10 sessions over 50 minutes. This is the definition of an extended session per year, and we've costed it at $146 per session. Now, why we called $146? It just happens the psychologists, that's what they get. So that was kind of the nearest ballpark figure. That obviously goes in and tries out. So the process is the application's been completed. It was to be reviewed at the November MSAC meeting, and we're really just in the process. Once, if we get a foot in the door at that meeting, then we'll start some sort of support campaign for the application. And I'd like to certainly thank John for his involvement in assisting us in that application. The next thing that came up was that the Breast Cancer Network of Australia published a State of the Nation report, and it was essentially a survey of people with breast cancer. And on the 32nd page of this report, which is very extensive, it noted that lymphedema was the top information need, which was identified by the respondents. So a third of them said they needed more information about lymphedema, to educate them about fears and to help if they where to go to. They noted that public health options were limited and variable, and services had reduced over time, and there was a long waiting list. So this was all in their report. They noted the cost of treatment for private practitioners was significant and a barrier to ongoing treatment, and there was an absence of a Medicare benefit. And a lot of the discussion within this was this incredible cost that people bear, even if you have private health cover, the cost of cancer and its subsequent management. So this went to the Commonwealth Minister of Health, and the BCNA ladies are pretty tough ladies, and they got in his ear, and he immediately said, "Oh, we'll do something about this." And so he said, "I'll write to all the state ministers and tell them that they need to adopt a consistent approach to subsidising compression garments," which he's done because the Minister of Health complained that he got a letter from this fellow. And there was a proposal for a forum and so on. Of course, we're coming up to elections, so who'll be in, who'll be out, I don't know. But at least there's some movement in that area. And it's really important to actually try and pull all these things together so there isn't one group complaining or staying. We wrote support through to the breast cancer, support to the Ministry of Health, saying that we thought this was a fine idea. So these are the sort of things that are going on. So hopefully, you never know what's going to happen in the new year. We never know, we might have 2 new state governments, Commonwealth governments, we'll all have to start all over again.